Thank you for inviting me to talk today about thyroid cancer. This is Erminia Massarelli. I am MD, PhD, Associate Clinical Professor and Thoracic Disease Team Leader at City of Hope Comprehensive Cancer Center in Duarte, Los Angeles area. These are my disclosures. The objectives today are to talk about thyroid cancer and to give you an overview in how thyroid cancer is diagnosed, which means discovered, how it is treated, and what are the long-term side effects of thyroid cancer. The thyroid gland is a gland that is present in the neck, basically surrounds the main windpipe, which is called trachea, and can develop basically some nodules, which are some little knots that in a majority of times are benign, which means non-cancer. However, sometimes they are what we define cancer, which meaning that with malignant transformation. About 52,000 new cases of thyroid cancers are estimated to happen in 2020, with 2,180 deaths. And thyroid cancer is the most common malignancy that happens in the endocrine glands. The incidence is rising due to a better detection and increased risk factors. And the incidence rate are higher in females. So in this graph on the right, you can see that on the left, you see the 5-year survival rates. So when the thyroid cancer is localized, meaning it only involves the thyroid gland, the survival rate, which means the probability to survive at 5 years, is basically almost 100%. And 68% of the thyroid cancer cases are discovered at this stage, so as localized. But then the thyroid cancer can spread outside of the thyroid gland to involve actually structures that are nearby. That's what we call about regional thyroid cancer invasion, and 26% of cases basically are spread to what we call lymph nodes. But still, the survival rates at 5 years are very high, about 97%. When the thyroid cancer spreads to outside the lymph nodes, regional lymph nodes, to other organs, for example, to the lungs, to the liver, to the bones, we call them distant metastases. And about 4% of cases of thyroid cancer are discovered when they're already spread to other organs. However, the 5-year survival rate in this case is half of it. It's half of the locoregional disease. It's about 54%. And 2% of thyroid cases have an unknown status at diagnosis. In this case, it's basically the 5-year survival rate is about 88%. In this picture, you can see that in the upper panel, there are the estimated new cases per year. And you see that the thyroid cancer in females is the 5th malignancy per incidence. So it's about 4% making 4% of all the cancer cases. However, likely the thyroid cancer is a cancer where the patients live for a long time. And in fact, if you see in the lower panel is the estimated deaths by cancers, and you can see that in the first 10, basically there is no thyroid cancer. So the types of thyroid cancer, the most common is called papillary thyroid cancer. It is a slow-growing disease, has good prognosis. Then about 10% of thyroid cases are called follicular and have still a fairly good prognosis. 3% of thyroid cases are called Hurtle cell thyroid cancer. And they also have a fairly good prognosis. And then there is another type of different thyroid cancers called medullary thyroid cancer that accounts for 4% of the thyroid cancer. And usually it has a high incidence of being inherited. So this could be, it's called familial medullary thyroid carcinoma, which accounts for 2 out of 10 cases of newly diagnosed medullary thyroid cancers. And then we have a very rare but very fast growing and aggressive thyroid cancer, which is called anaplastic or poorly differentiated, which accounts for 2% of all the thyroid cancer. And then, very rare, extremely rare, basically less than 100 cases per year, it's the cancer of the parathyroid, which are basically some glands that are by the thyroid. So which are the risk factors for thyroid cancer? So the first one is age. So 2 out of 3 cases of thyroid cancer occur between the age of 20 and 55. And mainly they occur in females. In fact, females develop thyroid cancer 3 times more often than men. Then radiation exposure, including X-rays. And then there are some other predisposing factors that are mainly genetics, and one important factor is iodine deficiency. Which are the signs and symptoms of thyroid cancer? So I told you earlier about the nodule. So whenever you palpate, or the physician palpates a nodule in the location of the thyroid gland, it should always be investigated. It could be also pain in front of the neck, difficulty breathing, swollen lymph nodes, usually in the neck, difficulty swallowing, because the thyroid gland could be enlarged and pressed on the esophagus, and persistent cough. How do we diagnose, so meaning discover thyroid cancer? One important exam, other than the physical exam, is ultrasound. So usually when a physician palpates a nodule, or a patient sometimes also palpates a nodule, then one exam that we usually advise is an ultrasound of the thyroid, because the ultrasound can detect very small nodules and can also look at the structure of the nodules to understand if those are concerning or not. Then there are blood tests that can be drawn. For example, one of the markers called thyroglobulin that will eventually guide us towards the diagnosis of thyroid cancer. And then the ultimate knowledge, and diagnosis of the nodule in the thyroid is actually biopsy. So usually after the ultrasound, if there is a nodule that is concerning, then a biopsy is advised, and then the biopsy is looked by a pathologist and the diagnosis is done. So then in some other cases, if the diagnosis cannot be established with the biopsy, might be needed a type of surgery, which is called lobectomy. And then there are some other imaging, for example, CAT scans or PET scans that are useful, or thyroid-specific scans. So I told earlier about early stage versus late stage. In this cartoon, you can see that thyroid cancer is classified according to the size of the nodule, of the cancer. So we say T, we name basically the staging T and M. T is for tumor, N is for lymph node, and M is for metastasis. So to let you know what it means early stage. So early stage, we classify a tumor when it's very small. So T1A, for example, is 0 to 1 centimeter. T1B is 1 to 2 centimeter in maximum diameter. T2 is 2 to 4 centimeter. Then T3 is tumor that extends minimally outside of the thyroid gland or is larger than 4 centimeters. T4A is an extensive tumor that invades structure with surgical resection still possible. So which means that basically surgery can still completely take away this, remove this cancer. And T4B is when it's too extensive so that even if surgery is done, unfortunately it cannot completely remove all the cancer. How is thyroid cancer treated? So the care of thyroid cancer should be done by a multidisciplinary team. Multidisciplinary team means that it's composed by different physicians, but also by other figures, for example, speech pathologist, the pathologist, the the radiologist, the lung specialist, the oncologist, of course, the radiation therapists, and the surgeons. So usually when the tumor is confined to the thyroid, when it's small, so we talked earlier about tumors up to 4 centimeters that are localized to the thyroid, then the first step is definitely the removal by surgery of the thyroid gland. And sometimes even if the thyroid nodule, the thyroid cancer is small, however, if there are some risk factors, and we usually find them after the removal by surgery, they might require the removal of the old thyroid to then being able to have another treatment after surgery, which is called radioactive iodine treatment. This means that because the thyroid gland can pick up the iodine, because that's what the thyroid cells do, they pick up the iodine and then they package it into the thyroid hormone. So the ability of the cancer cells to still uptake the thyroid, the iodine, basically makes this a very good form of treatment, so that if we render the iodine radioactive, then it will kill the cancer cells. And then the late stage thyroid cancer might need not only surgery, but might need radiation therapy, chemotherapy, and what we call targeted therapy, which means that we usually perform a molecular test on the cancer cells, and we look if they express some gene alterations that make possible to use some novel drugs that target the specific alterations. Usually these targeted therapy are oral drugs, so basically pills that can be prescribed. And then of course, in case of no other options available as standard of care, we do advise clinical trials, which test actually novel drugs or targeted therapy, for example. So I talked about alterations of genes in the cancer cells. So what we do today, in cases of thyroid cancer, we can order a molecular testing, which looks at different genes expressed in the cancer cells and detects alterations of these genes that could be potentially driving the therapy for these cancers. One of the most commonly altered genes in thyroid cancer is called BRAF, B-R-A-F. Here you see in this pie graph, basically, that the majority of papillary and follicular thyroid cancer have some of the alterations. The most common alterations are in the RAS pathway, it's called RAS, and in the BRAF, BRAF. You see, I put it in bold. And then we have others, for example, they are more rare. For example, RET, RET. This is very important because we have today two very good RET inhibitors, which actually are kind of life-saving because they work very well in RET mutated or fused cancers and can provide very long survival with minimal toxicity. And another very important mutation is called the TRK or NTRK. And we have, even if this alteration is very rare, however, we have very good targeted therapy that could potentially be used in this type of cancers if they relapse after surgery, for example, or if they spread to other organs. So also in anaplastic thyroid carcinoma, which is a very aggressive form of cancer that actually can grow within weeks or a few months to become, unfortunately, spread to other organs and become metastatic. We have found actually that there are available some targeted therapy that target BRAF, MEK, MEK, and also immunotherapy. So which are the treatment side effects that patients with thyroid cancer might have after treatment? So one of the most common side effects of surgery are neck tension and tenderness. They could have hoarse voice, so voice problems. They could have swallowing problems, especially if the surgery had to involve esophagus. And also they could have irritated windpipe, like for example, trachea, sore throat. Less common post-surgery complications are hematoma, decreased parathyroid hormone activity, which will require hormonal replacement, and what is called recurrent laryngeal nerve injury, which causes usually hoarseness. So in conclusion, thyroid cancer is the most common endocrine malignancy. It's very common in women. Survival rates are great for early stage cancer, thyroid cancer. Limited treatment options are available for late stage cancer, especially in the most aggressive types, such as anaplastic and poorly differentiated thyroid cancer. And supportive care is available for long-term side effects, especially from long-term from surgery. So I do advise that as soon as a subject is diagnosed with thyroid cancer, it would reach out to a very good medical institution where there is expertise in treating thyroid cancers and good multidisciplinary team that can take care of the entirety of the treatment and side effects of the treatment. And so we do have this amazing endocrine team at City of Hope. So I encourage you, for any question or any referrals, just call us at City of Hope and we'll be able to help you. Thank you.